Hi, my name's Jamie Lewis and this is my podcast on heart failure. So, what are we going to cover today? The first thing that we're going to cover is what is heart failure. Then we'll move on to the symptoms and prognosis, signs, classification, and then initial management that we'll do. So, what is heart failure? Heart failure is deemed as the final endpoint of most, and if not all, cardiac disease. The pathophysiology of heart failure is varied, but it generally follows this trend, as shown on the graph. First, there's an index event. This is an original insult that alters the ejection fraction. And for those of you that don't know, an ejection fraction represents the volumetric fraction of blood pumped out of generally the left ventricle. And this is measured by ultrasound, echocardiography. Most commonly, the original index event is some sort of coronary artery disease, with around 52% of heart failure being caused this way. And there are other notable causes that represent the other 48%, and that's atrial fibrillation, valve disease, hypertension, and alcohol. But as I said before, it is the endpoint of most heart disease, so anything can really cause it. After the original insult, that reduces the ejection fraction to below 60%, as normal ejection fractions between 60% and 85%. There's an increase in the wall stress of the ventricle. This causes cardiac remodeling and results in secondary damage and left ventricular dilatation. As you can see from the index event, the ventricle wall, as that's what the donut represents, dilates. And compensatory mechanisms such as the release of natural diuretics try to increase the ejection fraction of the heart back to normal. And the end result of this remodeling is complete failure of the heart muscle and ultimately death. So now we'll move on to symptoms and prognosis of heart failure. So the New York Heart Association released this table, as you can see below, and it links symptoms to prognosis. Class 1 is the most mild, and Class 4 is the most severe heart failure, and it's on a sliding scale from 1 to 4. So we'll talk about Class 1 now. These patients are generally well, and their heart failure is diagnosed from their reduced ejection fraction, which is probably being done for another cause. So these patients have no limitation on their daily activity. They have no fatigue, breathlessness or palpitation on their ordinary physical activity. And this is having a reduced ejection fraction and no limitations on your daily activity has an annual mortality rate of around 3 to 5%. Okay, so now we'll talk about Class 2. These are a step above Class 1. So these patients are comfortable at rest, but ordinary physical activity such as climbing the stairs or doing housework does result in symptoms such as breathlessness, fatigue, or maybe palpitations. So these patients can be diagnosed with mild heart failure. And this brings with it an annual mortality rate of around 10%. So, Class 3. Class 3 again are a step above Class 2, and they have a marked limitation of physical activity. So these patients don't get up to do the normal physical activity, as we said, climbing stairs, doing housework. They are prevented from doing this. Although patients are comfortable at rest, they can do less than their ordinary physical activity, and that will lead to symptoms. These patients have moderate heart failure, and this brings with it an annual mortality rate of around 12 to 16%. Class 4, as we said, was the most severe, so the symptoms that we're going to talk about will be the most severe. Patients have symptoms even at rest and are unable to undertake any physical activity without discomfort. And these patients have severe heart failure, and this brings with it an annual mortality rate of around 15 to 20%. So now we'll move on to talking about the signs of heart failure. So these are the signs that a patient will present with, and obviously the diagnosis of heart failure is a difficult one to make, but there are some general signs that you can be noted, and these will point you towards a more specific evidence of structural or functional abnormalities that you'll find on an echo. So the general sort of signs are tachycardia, tachypnea, pulmonary rales, pleural effusion, raised JVP, peripheral edema such as ascites or ankle swelling, and hepatomegaly. So I'll quickly talk through about why you get each one of these. It's quite interesting to relate the pathophysiology to each of the general signs. So a tachycardia. So obviously your body needs a basic cardiac output. And as we know, cardiac output is a function of heart rate times stroke volume. And when the ejection fraction is reduced, the stroke volume is also reduced. So therefore, the heart rate needs to increase to try and maintain the cardiac output. So on to tachypnea and pulmonary rales and pleural effusion. Tachypnea, pulmonary rales and pleural effusion are a result of pulmonary hypertension. Because the heart can't pump as much blood across the lungs, the pressure in the lungs increases, and therefore you get exudates, transudates into the lungs, causing the pleural effusions. The pulmonary rales are when the alveoli are full of fluid, so you get fine end and spiratory crackles bibasally heard on auscultation. And the tachypnea is because of the lung function is reduced, and therefore you want to get as much oxygen as you can through the into the blood, and therefore increasing the ventilation will help this. So on to the more specific signs of heart failure. We have cardiomegaly, the presence of a third heart sound, heart murmurs, echo abnormalities, and a raised BMP. So signs of cardiomegaly can be picked up from the chest X-ray, with the cardiothoracic ratio having over 50%. Signs on an ECG, such as tall R waves and left axis deviation. And also you can get a displaced apex beat on examination. A third heart sound, while not pathognomonic, is caused by the oscillation or sloshing of blood back and forth in the ventricles. Murmurs can be either a sign of an index event or due to cardiomegaly, as the valve annulus can be enlarged and a valve can become incompetent, such as the mitral valve. Echo can be useful to monitor the ejection fraction, but it also can be useful to monitor any abnormalities that can occur in the heart as an index event or something that's happened due to that. A raised BMP should be taken as a D-dimer is taken, so it has no positive diagnostic value, but can be useful to exclude heart failure, so it's worth doing as well. So it must be stressed that heart failure is more of a syndrome than a true diagnosis. It's a culmination of signs, symptoms, and reduced ejection fraction, and an increased BMP. But you can omit each part of this in the diagnosis. Okay, we'll move on to the classification now. So, now to talk about classification of heart failure. So, firstly we'll talk about the acute versus chronic, then the high versus low output cardiac failure, and finally the systolic and diastolic dysfunction differences. So, the acute versus chronic distinction can be useful to assess how urgent the management is needed. In a patient with long-standing heart failure, such as in aortic stenosis, there is compensation that can occur in the heart as it can remodel. However, with acute failure, there is a sudden change in the cardiovascular system, and this can cause rapid decompensation, and urgent treatment needs to be started. This can be an example of what happens after an MI. Heart failure is a decomposition of the balance between supply and demand. When the metabolic demands are high, such as in Paget's disease, the cardiac output cannot keep up with this, and this causes heart failure. When the cardiac output is low and cannot keep up with demands, then that is low output cardiac failure. The difference between systolic, in blue, and diastolic dysfunction, which is in red, is the preservation or not of the ejection fraction of over 40%. So in diastolic, the ejection fraction is preserved. Diastolic dysfunction means that there's impaired filling of the ventricle, and therefore preload is reduced, and the ratio of blood ejected versus preload is preserved. Systolic dysfunction is when the afterload or contractility is changed. This means that there's a normal preload, but the blood ejected is again reduced. Finally, we'll start to talk about management. However, this is covered, the pharmacological sides are covered in another PodMedics podcast. So we'll talk a little bit about patient education. We'll mention the drugs, but we won't go into any detail on them. And then we'll mention a bit of the surgery. Okay, so we know that heart failure is caused by different etiologies, and these should really be targeted in the management to ensure that they don't negatively affect the cardiac output. So dietary and exercise advice is something that we'd start with. There's a negative inotropic effect of alcohol, and therefore this should be restricted. Good nutrition and reduction of weight in the obese should be optimized. Avoiding high salt diets, and with this there should be care of use of salt replacements, as they can contain high potassium levels and should be restricted again in ACE inhibitor and spironolactone patients who are using those. Fluid restriction should be considered in patients with increasing weight over a short period of time, say under 6 weeks, as this indicates fluid retention. Aerobic exercise should also be undertaken, as it has been shown to be beneficial in patients up to the class 3 heart failure patients. And of course, smoking, as with every disease, smoking should be avoided, and smoking cessation services should be offered. So with prognosis, mentioning prognosis to patients can be a very sensitive issue, and it should be only broached when the patient's requested it or it's deemed that the patient needs to know. And you can relate this to the NHYA class, as it's been very well researched into. Symptom recognition and understanding of available treatments. So symptom recognition, you can put an element of patient autonomy into this. So understanding and recognising symptoms can help patients come to terms with their disease. It'll also help increase adherence to the treatments, their functional capacity and well-being. When symptoms, a patient recognises their symptoms are getting worse, then they can increase their diuretic or decrease their fluid intake and make sure that their symptoms are under control. That's just an example of how a patient can use their teaching of symptom recognition and understanding to help them manage their disease themselves. Patients are at an increased risk of infections such as influenza and pneumococcal pneumonia, and as we have immunisations for these, they should be immunised. As depression is a high rate in these heart failure patients, as around 1 in 5 patients with heart failure have depression, and as you get to the higher classes, it's quite pertinent to ask about depression, and referral to mental health services, including counselling, must be sought in these patients. So with drug management, treating the treatable is the aim. So ACE inhibitors, beta blockers, angiotensin receptor blockers, that's an ARB, diuretics, morphine, digoxin, statins and anticoagulants should all be optimised in these patients. In patients where ischemic heart disease is the etiology of their condition, surgery can be offered, such as stenting and grafting. With valvular patients, you can offer valvular surgery such as valvular replacement or valvuloplasty. Cardiac resynchronization is a form of dual chamber pacemaking where the heart is stimulated to beat in a synchronized manner. And this is indicated in patients with left bundle branch block with a sinus rhythm with an ejection fraction of less than 30%. An ICD, so an implantable cardioverting defibrillator, is common in these patients, as sudden cardiac death is high in these patients, with VF or VT scenarios being preventable with the ICD. Left ventricular assist devices are bridges to transplantation, where the left ventricular ejection fraction is augmented with the implantable device. And obviously heart transplant is the end stage of all heart failure treatments, and can actually work quite well, with around 30% of them surviving to 5 years. There are many problems with heart transplant, although with lack of donors and rejection requiring immunosuppression. So that's it for my talk today. I hope you liked it, and I hope to look forward to doing another one. Thank you very much. Bye.